let's take a quick look at my approach I've developed for managing a COPD patient. So obviously chronic obstructive pulmonary disease. So obviously it's going to start off the same as all the other approaches as with any case, is that you have a look at the standard precautions, so gloves, goggles, overalls. Moving on to dangers, have a look at the dangers. Your basic response: airway, breathing, circulation, hemorrhage. So are they conscious? Do they have a palpable pulse? Is there any external hemorrhaging? Is there getting good rise and fall of the chest? That really quick basic primary survey check. Then we move on to a very similar model to the asthma management, which is coincidence because COPD in the CPGs becomes asthma management in severe exacerbations. So obviously a history taking, do you have a history of COPD? Needing to ask that question. Have you been a smoker before? Do you have emphysema? Are you normally on oxygen? All those types of questions which can be really definitive in trying to rule out what might be happening, whether it is just an exacerbation of their COPD. One notable change I've made in the initial approach is that I've included SpO2 in the RSA, and normally I include that anyway, but especially in COPD I've made a special note of actually putting it down. That SpO2 is a really important indicator, because as we know with the COPD patient, it's no longer the CO2 which is their driving mechanism behind their breathing, and it's actually now a hypoxic drive. So we need to make sure that their oxygen saturations are okay, because that's actually going to have far more of an effect on their breathing compared to a normal person who would mainly be driven by hypercapnia or hypocapnia. So make sure you put that SpO2, and you can see the loop I've put in there. So SpO2 of less than 90, we need to, not skip the rest, but immediately you'd start thinking, alright, well, this person's going to need oxygen, because we want them to keep their SpO2 or their SATs at about a 90%. So I'll explain about that a little bit more, but obviously your RSA, so your appearance, speech, sounds, rhythm, rate, their skin, all that type of stuff. GCS, obviously getting a full GCS, verbal, motor and eyes. PSA, your blood pressure, your pulse, once again looking at the skin, capillary refill. And obviously your ample is really important, so they might be on a number of medications depending on if they're elderly or not, or if they have comorbidities. And initial diagnosis, so based on your history taking and your vital signs, is this actually just an exacerbation of their COPD, or is there something else at play here as well? And then you move into your initial treatment, which is what I want to talk about. So, as with the CPG says, manage it as per asthma in severe COPD. So that includes your salbutamol 10 milligrams, or the severe cases get the salbutamol 10 milligrams and Attrient 500 mics. So obviously treating a bronchospasm component of the condition there. But I have included one particular thing in that asthmatic regular management that is specific to COPD, and that is that we only ever to use low flow oxygen, because as I said, there's that hypoxic drive. So if we increase their oxygen sats too much and they have too much oxygen, their body's going to say, well, hang on a minute, we've got so much, let's stop breathing, or let's minimize our breathing, and that's obviously not what we want. So low flow oxygen is what's only used, and usually that's via nasal prongs, and we want to target around 90% for SATs, which obviously for anyone else would be quite low, but 90% is what we're aiming for with the COPD exacerbation. And then back into the regular asthma management of reassess the patient, and we can give another salbutamol dose 5 minutes later, being only half the dose at 5 milligrams. So then you're really just getting into your asthma algorithm, which is above on the page, you can have a look at. But yeah, that's a basic approach to COPD. It's quite simple because our management of COPD is quite simple. Obviously, with we don't want to, if it is an exacerbation, we don't want to increase their workload anymore. So things like not getting them to walk to the ambulance, get them on the stretcher, don't make them exert themselves is what we want, because we don't want to put their body under any more stress. And yeah, that's the basic management of COPD.